Good evening, everybody. This is Dr. Radialis from the Georgia office. I haven't spoken to you in a while. I hope everybody's doing really good. So today, it's going to be a question and answer session for those of you that are confused or have any questions about your particular case. I usually start the conversation by pointing out maybe an interesting case that has happened in the last few weeks. And one case I'm going to point out is an uterine adhesions case, okay, or Asherman syndrome. And this lady came to us about a year ago, and it was found that she had a polyp and potentially some uterine adhesions, but mild. She decided to go to an outside OBGYN to get her procedure done, and that was, let's see, she had it done January, February, and then she had no more periods thereafter. And she came back to us earlier in the summer, May, June, because she already went through IVF and she has a beautiful embryo she would love to transfer. But she kept waiting for the first day of her period. She was sent birth control pills by her OBGYN that did not result in a period. So eventually she comes back to us. She is even though she's a Georgia patient, she's about 2 hours from our office. So she was trying to do local monitoring to some degree. Anyway, she shows up in our office. We do a consult over the phone, and then we attempt a saline just to find out that essentially her uterus was shut closed, and that was the reason that she didn't have any periods. I mean, it was glued. We were able, with increased pressure, to see some of the fluid try to go through and create a tiny, tiny pocket at the upper part of the uterus. So, as you can imagine, she was very, very frustrated. And last week we decided to take her back to the operating room and with a special machine cut the adhesions open. And we actually had to use an ultrasound to guide, because when you're looking from the inside of the uterus, it just looked like a muscle wall. Okay, so it would be very easy to go in the wrong direction. So we actually use a transabdominal ultrasound, just like we do with the transfers, for those of you that have had transfers, to be able to make sure that we went in the right plane to open her uterus back up. And to our surprise and to her blessing, the upper portion of her uterus had normal endometrium. So once we got past that wall of muscle that had been created from the adhesions, then it went boop, and then we could see the top of the uterus very well. It is very important that if any of you have this procedure done, anytime you cut adhesions anywhere in the body, more adhesions can be formed. So we left a balloon inside to keep the uterus from gluing back up. We gave her vaginal estrogen to use, okay, and uterine supplements, enzyme therapy, for those of you that are familiar with these things, like serrapeptase, bromelain, protease. And then she came in the office for her first PRP. So we were able to do her first PRP, um, and do it with ultrasound guidance as well, just like we do a saline, in order to see how her uterus was healing. And it was truly joyful, both for the sonographer, myself, and of course for the patient, to see that for the first time in over a year, her uterine cavity looked normal. So my plan with her was to do serial PRPs. She's going to continue estrogen and add some progesterone later on, and get her to have a period. And then after her next cycle, we're going to do another intrauterine PRP to help that lining. And because there is normal lining at the end of the cavity, hopefully, just like the grass, like you have a patchy grass and it can grow into it. That's what we're aiming for. All right, so I see I have a few questions here. I had my first beta today after getting positive tests on a fresh transfer. Congratulations, very excited. When I'll be able to stop the Lovenox? I had no history of clotting or loss or anything. I would stop the Lovenox after we fully document a pregnancy. Okay, so honestly, I would keep you on the Lovenox until your first trimester is finished, because that's when the placenta is going to take over and make its own hormone. In the meantime, we're loading you with a lot of estrogen and progesterone artificially. So we usually keep the Lovenox until pregnancy is very well established. Depending on your medical history, your age, etc., you might want to stay at least on some baby aspirin, or even the Lovenox until you are on the third trimester. But that will be depending on your particular scenario. But congratulations on your positive test. What is your opinion about taking a break between stim cycle? Is priming okay? 46-year-old. So on 40 plus, on my 40 plus fabulous and fertile girls out there, I don't generally will recommend a dual stim. I will do 1 month, get a period, do another month, depending on how you're doing, how you're responding, because the IVF cycle actually is some sort of priming, right? You are pushing the way the biology of the body works. Imagine you're going to the gym. You're a fertility athlete. You're going to the fertility gym, and we're pushing those muscles just like you're pushing that, chest press, right? And then it's okay to give it a little break, but if you give it too much of a break, then that muscle will start getting a little lazy again. So if you're not responding appropriately, for example, we can take maybe a month or two just to do a little bit of priming and then start again. And priming for every doctor means something totally different. Priming for me, the Dr. V priming protocol would be a keto-ish diet, specific supplements, very clean food-based supplements, including glandular therapy. Okay, so if we're trying to heal the uterus, we take derivatives of uterus. If you're trying to heal the ovaries, we take derivatives of ovaries. Okay, and so forth. And then you can do Omnitrope or low dose ACG. And of course, I am a believer of the PRP. I use it and I have a lot of experience with it, so I really believe in it. Okay. All right. My wife found out she had Hashimoto's. If we're planning IVF this fall, so Hashimoto's is one of the many autoimmune issues, in the spectrum of autoimmunity. For people with any form of autoimmunity, you really want to clean up your diet, okay? Especially thyroid and wheat don't go well together, okay? So you want to eliminate all of the food allergens that are well known. For example, peanuts, nightshades, okay? Grains, even whole milk. I mean, one thing is using milk fat or butter and so forth. So I would definitely eliminate all of the typical allergens and anything that will trigger the immune system. And then we use we're big on immune protocols, especially like the Lovenox, like the other lady was saying, prednisone, Plaquenil, Humira, Prograft, all the way to IVIG. So if you're planning to do IVF this fall, then that's probably, you're going to be on an immune 3-4 protocol, and a lot of different supplements that support not only the thyroid, but the whole endocrine system. So, for example, for your wife, it would be very important for her to ingest something like kelp, which is a natural form of iodine, and thyroid supplements, okay, to keep that thyroid at bay using glandular therapy. And you can definitely reach out to me through Messenger. My name is right there. I'm pretty easy to find. And I can look at your case and give you a few more pointers, okay? When you're taking hormone meds, can it throw your period off? Absolutely. We're messing with your endocrine system, and our endocrine system, especially females, it's extremely sensitive. Even any stressor, any big stressor, a surgery, a death, you know, any stuff like that is going to throw it off. I had a fresh transfer in July, but sadly it failed. So I'm sorry. I noticed that after egg retrieval, I had so much pain. Yes. What happens, and that could be the reason that it failed. What happens is after an embryo transfer, after an egg retrieval, there's going to be inflammation in the pelvis, especially the more eggs you take out, the more inflammation. How do we take out eggs? We use an ultrasound guided, okay, just like we do the transvaginal. So we use the same thing, but we use a very long needle, poke your vagina, poke your ovary. So every egg that we took out is a hole in your ovary. So that hole bleed a little bit, and the ovary swells up. So inflammation in the pelvis is not conducive to a pregnancy. So I normally talk to my ladies that if they have a lot of eggs, they should just skip the fresh. And having a lot of eggs also puts you at risk of OHSS, so ovarian hyperstimulation syndrome. Okay. So yes, Miss Brandy, and the immune protocols. In general, I would say 50% of all fertility challenges are immune modulated. Okay, what does that mean? You don't need to have lupus or Hashimoto's to have an immune component in whatever health challenge you're dealing with. Just like you can have subclinical thyroid issues and subclinical XYZ, the immune system tends to attack whatever gland, whatever tissue in your body seems to be sick. And it's a natural mechanism of cleaning up. If the body detects that that organ is not doing so well, it tends to attack it, okay? And that's why because we assume that 50% of all patients have an immune component to their fertility challenge, that's why we use so many immune medications. Doing an ERA, Alice and Emma, this month after a chemical in June, negative. Okay. I just feel like I need to do them before. Okay, I agree. You have 20. Okay. Well, hi, Lisa. I'm going to talk to you on the 29th. You know, you are always, if you want to talk to me directly, you're always welcome to call Atlanta, and that is 770. I'll write it down for you, okay? The Atlanta office direct line is 770-266-3930, okay? And you can reach out to, 30. And you can reach out to extension 2274, 2275, all right? And then if we always, like for example, today I had a cancellation, but it'll be a last minute cancellation, maybe the same day or 24 hours before. And if you are on the waiting list to talk to me, then I can just squeeze you in and talk to you, okay? But you have to talk to either Jenny, Lisette, one of the front girls, or, you know, text me, I'll pass on the message. But then again, sometimes it's a last minute cancellation and we can try to squeeze you in if you need to talk to me sooner. Okay. Okay. So somebody might be at chance of DVT, which is a clot in the legs, and concerned about using birth control to shrink my cyst. Um, well, any fertility treatment will put you at risk of coagulation issues. So even if you use birth control pills to shrink the cyst that you're dealing with, you might have to be at least on baby aspirin or low dose Lovenox together with it. The other choice would be surgery. So I'll give you those two choices. Orlisa is used for 30 to 60 days before FET. So it really depends on what is the suspicion. I tend to use Orlisa or Lupron on patients that have documented endometriosis because they do so much better with their FETs. I prefer 60 days, honestly. It gives enough time for the medication to work and to eliminate all of the microscopic implants of the endometriosis that might be there, compromising the pelvis. Does a low grade egg stick? Yes. So it's very important for you guys to understand that the grading system that the embryologists use is subjective. What does that mean? It's like when you have a kindergarten, Dr. Kills uses this analogy all the time, and I love it. You have this group of kindergarten children, and they're not at an age that you can give them an exam and it's a very marked either had a right answer or wrong answer. It is subjective. It's like, well, this drawing, it's an A or it's a B or it's a C, right? But the grading system cannot determine if that is the next president of the United States when it's somebody's interpretation of how good the artwork is or how the embryo looks through a microscope. So a lot of low grade embryos do give a lot of beautiful babies. And sometimes we put all of our eggs, all of our points towards the AA, ABs, and it is the CC that gives you a baby. So every embryo is the possibility of a baby, and just see it that way. How would you time embryo banking okay. And cavity, okay. If the fibroid that they're going to take out from the inside of your uterus is not really going to push you back too much, depending on the size, I let people jump into a transfer right away or then have a period and then transfer. Fibroid removals gets really complicated when it is in the muscle of the uterus. That's when we have to wait 3 to 6 months to let it heal, depending on the amount of fibroids, the extent of the surgery. So, um, if you're trying to do embryo banking, you can do like round one and take out the fibroid. Then with the next period, do another round of IVF and then maybe transfer on the third period. Does PCOS women have to do PGT? You don't. So genetic testing on the embryos is completely optional. I think there's certain scenarios where PGT is worth the energy. One, like today, I had a couple that he has a known genetic disorder. So he has a problem with his bones that had caused him problems all of his life. And it is a dominant gene. So they want to make sure that the embryos don't have it. Absolutely. They're going to have a specific probe made for that, and they want to screen their embryos. Let's say you have 5 boys and you want a girl. Absolutely. Yes, I understand the value there, but just for the sake of screening, I'm not very much into PGT testing. One, because then you have the mosaics that could become normal babies. So what do you do with that? Then there's a lot of debate about the actual biopsy could damage the embryo. And the worst one, and that's the one that a lot of patients just go, it really, it's like a punch in the gut, is why didn't my normal embryo implant? So a normal embryo does not guarantee a pregnancy. Okay. How long can the benefits of PRP last for a patient looking to increase egg quality? So the way PRP works is that it improves, it's not like a medication, okay? So there's going to continue to be wear and tear, and that's when you're going to lose the effect of the PRP. So if you do a PRP, it's going to last, a few months. As you and then as you start aging, then the effects are going to fade off. Is it a good idea to prime with estrogen progesterone for women over 45? I don't consider that priming. When you give estrogen and progesterone for older women that have a not a great baseline, you're actually doing hormone manipulation and you're suppressing the ovaries a little bit with the idea of hopefully waking them up. Um, I have had to use estrogen and progesterone in people that are adamant about jumping into a cycle and they come for baseline and they don't have the right numbers. In general, they don't do so good. I rather try to help the ovaries work better. So when I send people for priming, I put them on letrozole, meaning again, the idea that you're working the muscle, right? It's the fertility gym. So I want them to have one or two good ovulation cycles before the actual IVF. That way, when they come for their baseline, it's a true baseline. And of course, PRP supplements, the whole nine yard. When should I take Lupron before my next IVF to help the follicles grow more evenly? Um, okay. Yes. So if we're going to do Lupron, then you want to take it about starting the luteal phase. So 7 days before before you get your period. That way we get a little bit more of a suppression and then start depending on the baseline. What was I going to say? So we could do several things. You can do a baseline and see when is the when what's happening. Are you getting a lead follicle, right? And then you can actually have a Lupron flare, okay, with the injection starting 7 days before your period. That way we're going to start recruiting, like your body is recruiting before your period. So we want to get on that wave. Imagine you're like, it's the wave of the FSH, and then that's where you would be starting. So 7 days before, so it's a luteal start. 7 days before your period, you start the Lupron together with the rest of the injections if that baseline is good. Okay. I know you guys have a lot of questions. That's awesome. All right. So why does a normal PGT fail? This is a good question. Because there's a lot of factors. Okay. In the IVF world, IVF has been around about 40 to like 50, 60 years. And even with all of the advancements that we've had, success rate across the nation is 50%. There's a lot of factors we don't know. Just like, hey, what if the actual biopsy misses a placentation possibility for that embryo? So there's a lot of factors we don't know, including divine intervention. So that is the reason that it's still a flipping the coin to some degree, even if you have a normal PGT embryo. And I've seen it all the time. They transfer the normal embryos, they don't work, they transfer the mosaic, and that's the one that gives the baby. So what is the success rate with a ACG wash? Um, so what does the ACG wash do? It kind of primes the lining to receive the embryo. What is ACG? Okay, it's human chorionic gonadotrophin. It is a hormone that it's only produced during pregnancy by the embryo, all right? So we're amplifying the signal that would normally be done on an embryo that's navigating through the tube going down, in nature. We're amplifying the signal to let the body know that it's pregnant. So it kind of primes the uterus to receive the pregnancy. Whether that one intervention is going to make the difference, I don't know, because sometimes what I see is that this one adds a little bit and this one adds another little bit, and then maybe that is what's going to tilt the balance in your favor. Due to tube blockage, my best option is IVF. Yes, if your tubes are blocked, then it's IVF. I don't recommend trying to unblock tubes. I know there's a lot of protocols. I was mentioning the enzyme therapy. And then you can try that depending on your age. But the fastest, surest way to get a baby if your tubes are blocked will be IVF. Do you recommend ACG wash over the boosters? Well, normally we do them together because you get half of the Ovidrel, the trigger shot, and do the booster, and the other half put it up there. I think I would like the ACG wash if I had to pick one of the two, because it's like you're sending the signal right where you need it. Okay. Do you think dual stim is worth it? So my experience with dual stim is that one of the two cycles do well and the other one not so well. So what does dual stim mean? That you retrieve and like 5-6 days later you start stimming again. On older ladies, that tends not to work very well. So either the first cycle goes well or the second one. And of course, every case is different, but if you put it across the board, that is kind of the experience. Sometimes I like doing dual stim when the first cycle did not do so good, because that means that there's still a few follicles that we can try to rescue from that stimulation, give a little break and go. So that's the one scenario where I see that second retrieval really add to the first one. So let's say the first one you got 2-3 eggs, but there was still activity. Then you give a break and start, and maybe the second one you get another 4 or 5 eggs. But if you got like 10 eggs on the first round, or you had a very good round, then the second one is like your ovaries are kind of tired, so they don't really give us a lot more. Yeah, and especially with older ladies, older 40 plus, and even with normal AMH, our bodies, even if they're making beautiful eggs, they just take a little longer to recoup, right? So then you want to give it that break. So on older ladies, I usually recommend most of the times retrieval, let the period come, retrieval if they want to do the back-to-back. Again, there's certain scenarios where the first stim and retrieval, it was a little off, maybe a lead follicle, there was something off about it, but there's still activity in the ovary, so we didn't harvest all that we could have. Those are the only scenarios that I see that the second one tends to grab those follicles that weren't quite ready on the first round. It is really when you have those lead follicles and the other ones that are lagging behind. Okay. All right, people, it's been a pleasure, as always, sharing some time with you. Again, if any of you need to speak with me, just either call the office and talk to one of the girls. So as soon as there's a cancellation, you can be squeezed in. You can also message me through Messenger. And Maribel Verdiales, MD. And I will see you guys back in 2 weeks. Have a blessed week. Bye-bye.